7 factors that determine how many eggs do you get in an IVF cycle. The number of eggs retrieved during IVF is one of the most important predictors of success. It influences how many embryos can be created, frozen, and transferred. While it might look straightforward, the actual egg yield depends on several biological and clinical factors. Here are 7 key determinants. Number 1. Baseline ovarian reserve. Your egg reserve sets the foundation for how many eggs can potentially be collected. Anti-Mullerian hormone AMH produced by small growing follicles. High AMH usually means more follicles available for stimulation. For example, AMH more than 3.5 nanogram per milliliter often correlates with high egg yield, while AMH less than 1 nanogram per milliliter suggests limited reserve. Antral follicle count AFC, the number of small follicles seen on ultrasound at the start of a cycle. An AFC of 15 or more usually predicts a good response, while fewer than 5 often indicates a poor response. Baseline reserve is stable over time, but it sets the maximum ceiling for egg numbers in any cycle. Number 2. Monthly variation in follicle recruitment. Even with stable AMH and AFC, the number of follicles that actively grow each month fluctuates. A woman with AMH 3.5 nanogram per milliliter and AFC 15 may sometimes only recruit 6 to 7 follicles, while in another month 20 to 22 may grow. This is due to natural variation in how many follicles wake up during a cycle. This explains why egg yield can differ between different cycles even with identical stimulation protocols. Number 3. Type of FSH stimulation drug. Follicle stimulating hormone FSH drugs are the backbone of IVF stimulation. Different preparations exist. Recombinant FSH, highly purified, consistent dosing, urinary derived FSH or monotropins HMG contain both FSH and LH activity. Some women respond better to one type than another, depends on their ovarian FSH receptor profile. Large studies show no universal best, but personal response matters. The drug must suit your receptors for follicles to grow optimally. Number 4. Dose of FSH. The dose of stimulation plays a critical role. Too low, follicles may not grow, leading to poor egg number. Too high, follicles may grow unevenly, asynchrony, reducing the number of mature eggs. Protocols are increasingly individualized. Low reserve patients may need higher starting dose, 225 to 300 international units per day. High responders, example PCOS patients, often require lower doses to prevent overstimulation and OHSS. Getting the dose right is as important as choosing the drug type. Number 5. Trigger type and timing. FSH grows the follicles, but the trigger shot matures the eggs and releases them from the follicle wall. Types of trigger: HCG, GnRH agonist, or a dual trigger. Timing: egg retrieval is usually done 34 to 36 hours after trigger. Too early or too late, the egg numbers drop. Dose: too little and many eggs remain immature. Too much and quantity may be affected. A perfect stimulation can still fail if the trigger is poorly timed or dosed. Number 6. Technical aspects of egg retrieval. The skill of the operator and the position of the ovaries affect the final count. Ovarian position: high or retroverted ovaries may be difficult to reach. Adhesions or scarring, endometriosis, or previous surgery can make aspiration harder. Empty follicle syndrome: rarely follicles yield no eggs despite looking normal on ultrasound. Even with good ovarian response, technical difficulties can reduce the final egg count. Number 7. Premature ovulation. If ovulation happens before retrieval, follicles may collapse and no eggs can be collected. Occurs in 2 to 5% of cycles. More common if trigger is mistimed or in women prone to early LH surges. Prevented by careful monitoring and antagonist protocols. Premature ovulation is rare but can wipe out a cycle's yield completely. Clinical perspective: high egg number more than 15, more embryos but higher OHSS risk. Moderate egg number 8 to 14 associated with the best live birth outcomes. Low egg numbers, less than 5, fewer embryos, but success is still possible with good quality embryos. A landmark study by Sunkara et al. Showed live birth rates rise with more eggs up to 15 but then plateau. Final word. The number of eggs retrieved in IVF is shaped by number 1, your natural egg reserve. Number 2, month-to-month variation. Number 3, the stimulation drug chosen. Number 4, the dose prescribed. Number 5, the trigger type and timing. Number 6, the technical aspects of retrieval. Number 7, whether premature ovulation occurred. Egg numbers are not random. With the right planning and adjustments, doctors can often improve the yield in future cycles.